अस्सलाम वालेकुम। मेरा नाम डॉक्टर आयशा नगीन है, प्रोफेसर of medicine, and this is for the third year's a clinical approach to anemia. So this is just a basic lecture and basic recording of what anemia is, and I'll be sharing the slides with you. But actually, obviously, everything is more um, it is more explainable when you guys are going to be in the class, inshallah ta'ala, right? So okay, so we're going to start the lecture, and this is just going to be a basic review, so it's going to be a short lecture. And whatever the the actually the practical approaches and everything we are going to be discussing in class. So what is anemia? So a clinical approach to anemia, right? So what is anemia? Anemia obviously is something that you guys already know by pathology and everything. A reduction below normal in the mass of red blood cells in the circulation, hemoglobin concentration, hematocrit, and RBC count. So if you see a hemoglobin in men less than 13, they are anemic. If you see in women or female, a hemoglobin less than 12, they are anemic. A hematocrit less than 41 in men, a hematocrit less than 36 in females. So an RBC count as well. So hematocrit is going to be less, hemoglobin is going to be less, and then you're going to say they're anemic. So these are your cutoff points for whether they're anemic or not. So pathophysiology. So pathophysiology, I'm not going into it, but you know the normal erythropoiesis. So basically the hemoglobin is made in the bone marrow, the kidneys, the erythropoietin is released from the kidney, and that helps in the production of the RBCs. The liver play a part, the spleen plays a part because it because it's going to break down the red blood cells that are not normal or the regular breakdown. So all these things are involved, and that is how when you are going to be discussing anemia and the reasons of anemia, going to be looking at each of these parts, whether the bone marrow is playing its part, whether the erythropoietin is being released by the kidney, by the RBC, and or the is the spleen is the spleen doing undue destruction of the RBCs? So these are the things that you're going to be looking into. So you should know your pathophysiology, and that is how it's going to be that is how it's going to help you find out what actually the cause is. So at the start, and I'm going to be keep on repeating the same sentence, that finding out a person's anemic is not a big deal. So finding out why he's anemic is the actual big deal, right? Okay, so you know that if a person is anemic, the RBC, the oxygen is carried by the red blood cells, and the oxygen is not going to be released, and then there's going to be, so if hemoglobin is not going to be there, the oxygen is not going to be released. So we're not going into that either because you already know that. So when there's a decrease in RBCs, there's going to be a diminished oxygen carrying capacity, the hypoxia and hypoxia-induced effects of organ functions, and then the signs and symptoms of anemia develop. So this is the whole process of pathophysiology process of how and why the anemia is going to develop. So this is my main slide. So this is my main slide, the classification of anemia. So the pathology and physiology and anatomy and everything, I would have presumed that you already know because I'm taking a medicine class. So we are more interested in the diagnosis of anemia and how we can diagnose what is the cause and how we can treat it, because your treatment is going to be depending on the cause of the anemia. So on the basis of cause, we are going to be doing this later. Anemia can be classified as blood loss, inadequate production of normal cells, or excessive destruction of blood cells. We are going to be discussing this later, but mainly on the basis of morphology, it's normocytic, microcytic, and macrocytic, right? So normocytic, microcytic, and macrocytic. So this is your main classification. We're going to go into that. So, okay. So hemoglobin and hematocrits are concentrations. I don't think we're going to be going into that. We'll do this later. Okay, so first I'll discuss the normocytic. So according to the MCV, we are going to be discussing whether the anemia is normocytic. If it's microcytic, it's less than at MCV is less than 76, we call that microcytic. If it is more than 100, it's macrocytic. If it's normocytic, it is between 76 to 100. So this is my main classification, and this classification again will help me finding the cause, because if for example, iron deficiency is going to be microcytic. If B12 folate deficiency is macrocytic. So just looking at the MCV, I can see which of the causes there is. The four etiologies of anemia. Why does anemia occur? And it has to be in between these four: decreased RBC cell production, increased RBC cell production, red blood cell loss, or red blood cell sequestration. So decreased RBC production is because of a deficiency of iron, B12, folate. The bone marrow does not have the raw materials to make RBC. Bone marrow is dysfunctional. There is tumor, there's leukemia, and that is causing the marrow to be dysfunctional. Aplastic anemia, the bone marrow is not working. Maybe there's an autoimmune process that has caused the bone marrow to be suppressed, a viral suppression, maybe due to drugs, maybe due to radiation. The bone marrow is not working. The bone marrow is suppressed, or the low levels of erythropoietin released from the kidney, or a thyroid hormone, or androgens. These three hormones help in the making of the RBC. So a decreased RBC production, increased RBC destruction. We just talked about it, the splenomegaly. So RBC lives around 100 to 120 days. If it's autoimmune hemolytic anemia, TTP, HUS, DIC, malaria, these are causes where the RBCs are destroyed. Inherited spherocytosis, sickle cell, or thalassemia. So these are conditions. If it's inherited, means there's a genuine problem with the RBCs and their morphology, and that is why they are automatically being destroyed when they come into the blood. Acquired means that because of splenomegaly or some outside autoimmune antibodies or due to some bacteria like in HUS, the RBCs are destroyed. So RBC loss, very easy. There's bleeding, there's hemorrhage, there's melena, there is surgical cause, there's PIH, there's hemodialysis, there's excessive bleeding due to any cause. So microcytic less than 80, we call it 76 to 80. There's some where they call it 80, some of them they say is less than 80. So iron deficiency, thalassemia, lead poisoning, right? So lead poisoning, thalassemia, iron. When you see an MCV of 74, 65, either you think of iron deficiency, thalassemia, or lead poisoning. Normocytic, acute blood loss, chronic disease, bone marrow failure, hemolysis. These are very, very important causes of normocytic. Macrocytic, greater than 100, B12 or folate deficiency, straight away, right? So the differential causes is microcytic, normocytic, and macrocytic. This is just a view of the same thing that I was talking about. We'll discuss this more in class. So if there's an increase, okay, so these are again the same causes. We're doing the causes again and again. If there's increased requirements, for example, even then there can be anemia. For example, in pregnancy, lactation, if they're growing infants, or there's erythropoietin treatment, you do need more RBC. So you need increased requirements of folate and B12 and iron. Increased loss, again, the same thing, the bleeding thing that we were talking about. Decreased intake. Vegetarian diet causes decreased iron and decreased B12, decreased absorption, right? So upper GI pathology, celiac, Crohn's disease, these can cause sign and symptoms. So then there's decreased oxygen delivery. There's going to be fatigue, lethargy. They're going to come to you with shortness of breath on exertion. There'll be fatigue, palpitation, lightheadedness. If there's iron deficiency, they'll tell you that vomiting khata hai, pica, that is called, right? Craving for ice, severe heart. And if there's really severe anemia, then there's going to be oxygen deprivation to the heart, and heart failure and angina can occur. Symptoms, again, the same thing, dizziness, pale skin. Yeah, and shortness of breath. So the important things to ask in a history, this is the most important thing. If somebody comes to you and you think that there's anemic, you're just taking a history, you've not done the examination at present, so you're going to be asking past medical history of anemia. Did they have anemia again and again? Maybe it could be some inherited disorder. Is there family history, for example, in thalassemia, nutritional intake, bleeding, maybe the patient had been bleeding, maybe there's some GI bleed, maybe due to menstrual bleeding was really, for example, in females, it could be menorrhagia. Addictions of any kind, because gutka causes a lot of anemia. We see a lot of patients in chronic illness, environmental toxics, and changes in body weight. So signs of anemia, you will see pallor. If there's hemolytic anemia, which we'll talk of later, this jaundice, there's atrophy, koidonychia, or spoon nails, that happens in iron deficiency. Petechiae and ecchymosis happen if there's a decreased platelets and decreased hemoglobin. So that can be bone marrow suppression. Splenomegaly, lymphadenopathy, that can be found in either that can be found in hemolytic anemia or lymphoma, leukemia. So tachycardia, tachypnea, murmur is something that is definitely a sign of anemia. And if in stool, there could be black stools or some, depending again on the causes. So these are very generalized symptoms. It depends on the cause again and again. Again, brittle nails can be happening if there's malnutrition. Polynokia, which is a spoon-shaped nails due to iron, atrophy of the papilla if there's B12 deficiency, angulostomitis if there's B12 deficiency, dysphagia, glossitis that can happen in B12 deficiency, right? So these are the things that we'll be doing, like this is polyonychia in this one, and these are the glossi, and this you can see the difference in a doctor's hand and a patient's hand. You can see the palate there and in the eyes. So these are things we'll be discussing in class again. This is the symptoms. Anemia caused by iron deficiency. So this is just like a simple view of all those important causes that we will be discussing later. So for example, anemia caused by iron deficiency. So again, you'll be either having a history of blood loss or something, or a history of lack of like lack of meat, lack of iron. You'll see a pica, a dirt. They give you a hunger for strange substances, and you'll be seeing polyonychia. There'll be soreness and cracks. If it's due to B12 deficiency, a very, very important thing, there'll be neurological symptoms, a tingling, pins and needles, lost sense of touch, a wobbly gait, clumsiness, any neurological symptoms with anemia, you definitely have to rule out B12 deficiency. Okay. So yeah, and then there's a big chunk of hemolytic anemia. It's a very, very big chapter. So it's not, I'll just give you a overview. So hemolytic anemia is that the RBCs are being broken down quickly, like less than in 120 days. And when they're broken down quickly, there's a lot of heme produced, and there isn't that much glucose acid to conjugate them. So then there'll be anemia, there'll be indirect bilirubin raised, unconjugated bilirubin, and there'll be splenomegaly because of such a big amount of destruction that will be happening. The spleen will have to be working more, and there's going to be splenomegaly. So there are a lot of inherited and acquired causes. There can be sickle cell, thalassemia, G6PD deficiency, autoimmune, hemolytic anemia, hereditary spherocytosis. Acquired is viral or parasitic infections. What you need to remember really, really strongly is that this triad, anemia, jaundice, splenomegaly, is hemolytic anemia. Anemia of chronic disease is when there's a very prolonged inflammatory infectious or neoplastic diseases that persist for a very long time, like rheumatoid arthritis, diabetes, anything like that. There'll begin to be normocytic, normochromic anemia. The ESR are going to be high. You do not treat the anemia, you treat the underlying disorder. Aplastic anemia, bone marrow suppression, reticulocyte count decreased, and peripheral pancytopenia, hypoplastic, aplastic bone marrow. So the bone marrow is really suppressed, and it could be due to any kind of infiltration. It could be due to chemotherapy, it could be due to drugs, or it could just happen on its own. And when that happens, there's going to be a reticulocyte that will be decreased, the bone marrow will be suppressed. So on the CBC, you'll not be just seeing a hemoglobin low, you'll be seeing platelets low, you'll be seeing TLC low. So peripheral pancytopenia with hypoplastic or aplastic bone marrow, and the bone marrow biopsy, you'll be seeing this, and you'll be treating accordingly. Bone marrow malignancies, bone marrow infiltration by malignant cells. So if some leukemia, lymphomas, or multiple myeloma happens as an extra malignancy, definitely there's going to be bone marrow infiltration. So the normal cells are going to be pushed away, and they are not going to. So again, you'll be finding pancytopenia or hemoglobin. Whatever cell line is affected, hemoglobin is going to be low. Right, approach to anemia. Again, this is just an overview or slide of approach to microcytic anemia is iron deficiency, thalassemia, which is a part of hemolytic anemia, sideroblastic like lead poisoning. These causes microcytic anemia. Normocytic is low. Normocytic can be divided into high retic count or low retic count. Low retic count means there's inverted protection. The bone marrow is not working. So that is aplastic anemia is the one that you need to remember a lot, or infection infiltrations. High retic count means that the bone marrow is working, but there is a normocytic anemia, and that usually happens in hemolytic anemias. So that's why Coombs positive is autoimmune hemolytic anemia, or it can happen in like anemia of chronic disease, right? So then this macrocytic is very easy forward, folate deficiency or B12 deficiency. These two are the ones that you need to remember very strongly, and they happen in vegetarians because B12 is found in meat. So vegetarians often have low B12 deficiency. So investigations depend on the suspected diagnosis based on history examination. So macrocytic megaloblastic anemia, if you think there's MCVs increased, you do B12, you do folate acid, you do peripheral smear, you do a biopsy. If you see this pancytopenia, all three cell lines are, you're thinking of aplastic anemia, you're going to do a retic count, which will be low, and there'll be a bone marrow biopsy. which obviously will tell you whether there is or not. If you see that there's an iron deficiency, then you are going to go for a serum ferritin test, which is going to be less. Then go for a TIBC, which is increased. There'll be serum iron, which will be less, right? So investigations in hemolytic anemia. So if you think that, oh no, I'm finding anemia and jaundice and the splenomegaly, I'm definitely thinking of either thalassemia or autoimmune hemolytic or maybe sickle cell, then you'll go for a peripheral smear, LFT, and reticulocyte counts and hemoglobin electrophoresis, Coombs test. You'll do a lot of these panels to find out which hemolytic disease it is or G6 level deficiency. So there's a big range of hemolytic anemias, and you're going to be doing each and every investigation for each of them to find out which actually you think it is. So identify the type of anemia, identify the cause of anemia, and then you're going to treat the anemia according to the cause. And this is it. So if you see there's iron deficiency in you find low levels of serum ferritin or iron, you're going to start iron supplements. You're going to see why they were bleeding, what they're bleeding. So if there's menorrhagia, you're going to treat the menorrhagia. If there's melena, you're going to find out what is the cause of melena. G6PD deficiency is a hemolytic type. If you see this G6PD levels are less, then you're going to avoid medications that can cause G6PD deficiency, right? If you see there's a sickle cell anemia, you did a hemoglobin electrophoresis and the sickle cell was there. So then you're going to relieve the complications. You're going to treat according to a sickle cell. A thalassemia, you're going to treat according to it. Maybe you're going to do transfusions and then a bone marrow transplant and whatever. B12 folate, if you see B12 is there, you're going to do a B12 supplements. If you there's a folate, you're going to do a folate. If you think that there's a low folic acid, then there's a low folate level, then you're going to be giving folic acid. Aplastic anemia, then you're going to do immunosuppressive therapy and accordingly, right? So this was just a very, very short overview of what of the whole of the slides that I had. But actually, I think it's more anemia is something and medicine is something that you are going to be interactive session that you're going to be that you're going to be when attending the class, you're going to be actually learning exactly when we talk about it in more detail. Thank you very much.